Good morning, good afternoon, whichever part of the world you're in. Welcome back to season 2 of the RCSI Global Surgery Grand Rounds. This would be our season premiere. Thanks for being here. We have a really good topic on for today. We've got 4 speakers coming from 2 different institutions to discuss the value of surgical mission trips in the global surgery space. As Deirdre has put in the chat box, the 4 speakers will be speaking for about 40 minutes, and then there'll be time afterwards for questions. Please don't necessarily feel like you have to wait till afterwards to ask your questions. There's a Q&A chat box at the bottom of your screen. You can type in questions at any point in that Q&A chat box, and we will address them to the panel after they're done with their presentations. So let me briefly introduce our 4 presenters, and then we'll get started. First, from West Michigan surgical specialists, we have Dr. Joel Green and Dr. Eric Mitchell, who will discuss their practice's long experience of doing surgical mission trips to countries including Rwanda, Burundi, and Togo. They were recently featured in the Bulletin of the American College of Surgeons. And then from the Department of Surgery at Wright State University, we have Dr. Priti Parikh and Ms Musunga Mulenga, who will discuss their recent research, which was published in JAMA Surgery, which examined local staff perceptions and expectations of international visitors in global surgery rotations. So with that, I will turn it over to Dr. Green and Dr. Mitchell.
Good morning, thank you. Tell me if you can't hear me, please. My name is Joel Green. I'm a general surgeon in Grand Rapids, Michigan, and I've been in practice 10 years now following my training. All of my training was in Michigan, but as a part of my practice, a pretty big part of my practice is international mission trips as well. And that all started back when I was in residency. I'm going to share my screen here. I have a few slides, a few pictures to share with you. Let me see if I can get this going. Bear with me for a moment. So as a resident in 2009, third-year general surgery resident, I had a 1-month rotation where I had the option to travel overseas. And I found myself at Kibogora Hospital in Western Rwanda. It was my first international medical mission trip. It was an amazing time. I worked with a mentor who was a seasoned veteran in international surgery, had seen all of the crazy tropical medicine presentations that we don't usually see in the US. And I had a fantastic time with him. I have a few pictures of, this is a background from the rainforest in Rwanda, and just a few pictures of the hospital to give you a feel of the setting we were at. And then I'd like to give you just a brief background. This is my first trip to Kibogora. I had no idea about, or not much of an idea about the history, but I learned that over the years with repeated trips back to this same location and through some relationships I've formed there. So the whole thing started in 1942 as a church mission station of the Free Methodist Church in the US. And like many mission stations, it had multiple aspects of the care they provided to the people in the area. So it was an orphanage and a dispensary. And as time progressed through support through the church, it developed over many years into a full functioning hospital, providing maternity, pediatrics, internal medicine, and surgery services. They developed a nursing school, and most of the staff actually was full-time missionaries or nurses, missionary nurses. And then as they trained more and more medical assistants and nurses, the staff transitioned to a more Rwandan, a more percentage of Rwandan staff. To the point that in the 80s, as the government hospital system in Rwanda progressed and the medical care grew, there was a hospital system created, and Kibogora joined that hospital system. So they were partially church-owned and partially government hospital. During this time, there was a thought of nationalization of the hospital, and the missions organizations, as they did in the 80s, talked about passing off control of the hospital to the nationals and sort of pulling back the international component. But we pretty quickly realized in a couple of organizations that I've served in, one called Central Africa Healthcare Organization, another called Better Together, which is a group of NGOs from the UK, Netherlands, and the US. Pretty quickly learned that nationalization fails because of resources, and especially in a very small rural community where there's not a lot of resources. So that was kind of one of the things I've learned over the years, was the importance of what we call internationalization, supporting partners who integrate with those who live in the country year round and are more familiar with the needs of the people and can help develop programs that make sense in that cultural context. So that's a little bit of background and kind of where we're at now with Kibogora Hospital. However, as a medical student, this is what I saw and was overwhelmed by. A sea of people coming to, this is actually a picture just outside the surgery clinic where we saw maybe 70 or 80 consults a day on the one clinic day we had per week. And it was a fantastic experience as a resident because I probably did 2 or 3 months worth of operating in that 1 month. So great for my surgical skills. And then I left. And, in my mind was the fact that Kibogora as a hospital continued. And so I became involved in an NGO in the US that kind of provided me an opportunity when I couldn't be there to also partner with Kibogora Hospital to continue their work and improve the capacity of the hospital. Central Africa Healthcare Organization is a small NGO, but supports 4 hospitals in Central Africa. And primarily looks at capacity building. How can we improve buildings, programs, specialist training, providing scholarships for nursing and even some scholarships for doctors to become specialists. And in that way, even when I haven't been there present at Kibogora, which is one of the things I love to do, is travel there and spend several months rekindling relationships and providing surgical care. But there's a longitudinal involvement as well that I can help to support the work that's going on there all the time. One of my favorite stories is about this young man. He's actually my same age, so he's becoming an older man, but his name is Dr. Ronald Tubasimi. And I met Ronald first when I was there as a resident. He was a medical student at the time. And he had an aptitude and an interest and really a passion for surgery. He loved it. And so over the years, as he progressed through medical school and then was an intern doctor and became a general practitioner at Kibogora, the organization that I'm with worked with him to provide a scholarship for him to go to a PACS general surgery training program. He went to Ethiopia to a PACS training program. It was a 5-year general surgery residency. Some of you may recognize the name PACS. It stands for Pan-African Academy of Christian Surgeons. That it has several training programs throughout Africa. He received his training in general surgery. He passed his certifying exams and became a COSEXA fellow, and then returned to Kibogora Hospital, where I saw him perform surgeries I didn't know how to do. He taught me some urologic surgery, some interesting plastic surgery and flap creation. And I learned a lot from him in the operating room, but probably the most interesting thing I saw was the way that he could interact with patients that I was not able to do. Knowing their language, understanding their culture. He really could connect with patients on a level that was much more natural than what I usually had to do through an interpreter. So it was neat to see that. And then over the course of the next few years, he's been in practice now 5 years at Kibogora Hospital. As a COSEXA fellow, he applied and received certification as a training center for COSEXA. And so the relatively new general surgery residency training program in Rwanda at the University of Rwanda sends residents to him on a monthly basis and sends medical students to the medical school at University of Rwanda sends medical students to be trained by Ronald. And it's one of their favorite each of the residents has said it's one of their favorite places to be because of the wide variety of general surgery procedures he does and the volume they get there. So it's been a really an unexpected joy to be part of his training and seeing him mature as a doctor and having a longitudinal relationship with Kibagora Hospital, whether I'm actually present there physically or not. That's all I have. I'm going to turn it over to Dr. Mitchell.
All right. Thanks, Joel, for giving us some of the background of your story. I know this is a very big, broad conversation about the pros and cons of short-term medical missions. And so what I wanted to do is just give you, number one, a little bit of my story, and then number two, some salient points from kind of what I've learned through my experiences. And then hopefully we can answer a lot of your questions during the chat time to really get into what's important to you guys as the attendees. So just like Dr. Green, I function as a general surgeon. We're actually partners. I've known Dr. Green for a long time, and we trained together. And just like him, I did a 1-month rotation as a resident overseas in Peru. And I had always had a strong passion and interest to use my surgical skills to serve, folks who needed it the most, the folks who didn't have great access to surgical care, and was really interested in going overseas full-time as a full-time medical missionary. When I graduated from residency, after a short time working in the States, I took my family of, at that time, 4 boys and my wife, and we went to Kenya, and we lived there for 2 years. We worked at Tenwick Hospital through the guidance of World Medical Mission. And it kind of was like a fellowship, learning how to do surgery, learning how to teach in another culture. And I had mentorship of seasoned missionaries that had been there for 20 years. We then came back to the States, and God has a funny way of working, and your plans don't always line up with his. And for various reasons, we found ourselves back here in the States. And so now I've committed to staying involved and doing some short-term trips. So I've seen it from both sides. I've been the person at a hospital for 2 years, which is probably the longest short-term trip you can take. And we hosted many short-term visitors who had come from maybe 2 weeks to a few months. So I know kind of what it's like to host, but I also know what it's like to drop in, and then leave after a few months. So I've been to Togo, we've served in Burundi, we've been to Ethiopia. And I think the most important part of each of these trips is we have relationships at those hospitals. And so I think one thing to remember, big picture, is that short-term trips have a lot of variables, a lot of differences. They're not all created equal. There's different hosts. There's the people that are native to that country. There's the nationals who may run a hospital. There may be some full-time expatriates running a mission hospital that are from the US or the UK. And you're going to have different cultural interactions with each one of those depending on who your host hospital is. There's different types of guests. There's the single person that's going. There's the family that has to be hosted. There's sometimes a whole group bringing nurses, surgeons, techs, anesthesia folks. And there's various levels of training of each of those guests. They could be an attending, fully fledged physician, could be a resident who is learning, could be a student who has almost nothing to add and actually is going to be learning themselves and can, tend to be a little bit more work than what they're going to add. There's lots of different situations. It could be a team that drops in for 2 weeks, has the plan of doing 50 surgeries, and then departs 2 weeks later, never to be heard of again. It could be a short-term trip, anywhere from 2 weeks to 2 years, where the the person, comes in and can add something to that hospital that they don't have already established. It could be disaster relief, a hurricane, an earthquake, COVID, a war, where they come in to help alleviate some of the burden of massive disease. And then in the case of Joel and one of my other partners, Dr. Mike DeYoung, it could be where you come in and join and partner with a full-time physician like Dr. Ronald, where you're providing a vacation, offloading of cases, time to do research, time to do administration, and it's a partnership. So the question of should we endorse these trips or not, should we encourage them, should we support them, I think has some variability to it. There are some that maybe we shouldn't, and there are some that absolutely we should encourage people to do. These trips can be costly. Coming from the United States over to Burundi or Kenya with my family of now 7 of us total, it's about 20 to 25,000 US dollars. Maybe it would be better if I just stayed home and I sent that money over to Burundi, where they could pay for innumerable staff for the year. Potentially, the short-term physician is going to bring with them an attitude that may be more destructive than helpful. Maybe it's somebody who thinks they're the savior of that country, and they come with all the new information and the abilities to help where it doesn't exist. Maybe that person comes and has a very pretentious attitude, and in the operating room tends to be very demanding and belittles the staff, and now is breaking relationship with the United States and Americans or Europeans and whatever that host staff are. One major difference for short-termers when I'm coming from the United States is that it's a totally different disease process burden in the lower income, lower resource countries. When I first got to Kenya, I was overwhelmed with no idea what to do with many, many disease processes. Whether it's an ascaris bowel obstruction, a urethral stricture that needs a urethroplasty, whether it's metastatic prostate cancer. I was only trained as a general surgeon. I had almost no urology training, no neurosurgery training, very little pediatric surgery training. And so really for my first probably 6 months to a year, I was not super helpful. I was more of a learner than I was an actual doer. And I very much appreciated my Kenyan colleagues who were brilliant and who knew the disease process of their region. And another big thing that I think short-term folks don't realize is that it's not just the medicine, it's the culture. It's easy to do a surgical procedure. It's harder to really understand everything about that patient, where they come from, their resources, and it takes many, many years to learn the culture of the people that you're coming alongside. Some of the pros, why I would totally endorse and support people going on short-term trips, is that, as Dr. Green is a perfect example of, is it increases the friends and the champions of your institution from around the world. Hosting people, getting to know them, having them see your institution as something that they have a part of, can really create a bond and a lasting friendship that has lots of resources associated with it. Manpower, relief, financial for capital campaigns, encouragement, and the relationship that Dr. Green and Dr. DeYoung have with Rwanda is awesome. I still have friends and colleagues from Tenwick that I keep in touch with from Burundi, and I think that goes a long way. Even though I I'm not there all the time. I still can contribute with my time and my finances. Like Dr. Green and I, we both had exposures to overseas trips as a resident for 1 month, and those have led to a lifetime of desire to serve and be a part of those places. So early exposure may lead to a long-term commitment. It may lead to somebody going and saying, I want to make Kenya or Togo or Burundi or Rwanda my permanent home, even though I'm a Westerner from the US. It's always great to bring new ideas and have cross-pollination and allow and provide some education. Dr. Green and I have both been a part of PAC's surgery residencies where we train national surgeons in that country, and so that they can eventually stay and serve their people. And sometimes visiting surgeons can provide a surgical technique or expertise that is not provided at that hospital. When I was at Tenwick, we hosted a urologist a couple times a year, and that urologist would bring the ability to do urethroplasties, which is a pretty complex reconstruction that not even every urologist in the US does. After doing 5 or 10 with him, he then left, and now me, as the quote unquote full-timer who's there for a couple years, had that skill set I could do on a daily basis with my patients. And I've seen that with other colleagues with repair of myelomeningocele, cleft lips and cleft palates, as well as more complex pediatric diseases. If there's anything that I want folks to remember is that in order to make this work, I think it takes generally a positive attitude from the visiting and traveling surgeon or traveling physician. No matter the duration, no matter what you can bring as far as physical additions, the mentality of the visitor can make or break the trip. You have to have no expectations, be flexible, and not be high maintenance. You have to be humble and teachable to be a good guest. Don't be ethnocentric and think that you have all the answers. Have an attitude of partnership and empowerment of the local physicians, and have proper motivation. Have it not be about you, about your good feelings and what you get out of the trip, but love the people you're going to serve and have a passion to see them prosper. Because when it's about your own good feelings, when your good feelings go away, you'll stop serving. And everybody knows that when the going gets tough, that's when it means the most. So sorry I've gone a little long. I'll turn it over to my esteemed colleagues.
Thank you, Dr. Mitchell, Dr. Green. I'll turn it over to you, Dr. Parikh and Ms. Mulenga.
Thank you all. Hello, everyone. I'm really, really excited to be here today and be part of this very rich conversation. It's quite an honor and a privilege to be sharing this virtual space with you all. So thank you, Dr. Shrime and the Royal College of Surgeons for inviting us to talk about a topic that we're very passionate about. And we're going to talk about it with more of like a research context. And our paper, which this presentation is based on, entitled Local Staff Perceptions and Expectations of International Visitors in Global Surgery Rotations. And this body of work was actually inspired by some of our own experiences, as both Dr. Mitchell and Dr. Green mentioned. You know, when we as medical students or as residents or as even surgeons travel abroad to participate in service learning experiences or global surgery electives, we often find ourselves asking a lot of the same questions that Dr. Green and Dr. Mitchell mentioned, you know, like, what is our impact here? What is the impact of our presence? Are we actually being helpful, or are we just in the way? And we wonder what the host facility staff think of our presence. And these questions served as the impetus for our project. So in true research fashion, I'm going to give a quick overview of what we're going to talk about today. I'll provide some background and context for our research. I'll clarify what our study objectives were, and I'll also explain our methodology. And then Dr. Parikh will go ahead and share our results, offer our conclusions, and our next steps. So over the last few decades, we've seen that medical students, surgical trainees, and surgeons have shown a significant growing interest in global surgery. For example, a national survey study among resident members of the American College of Surgeons found that 92% of respondents were interested in participating in international electives. Why? A majority of them say they were motivated by the notion of giving back through short-term mission trips. Less of them indicated that they want to work in private or public sector of global surgery. And a smaller segment of them say that they're interested in a career, establishing a career in global surgery. And the literature regarding career aspirations for residents is actually pretty well documented. Overall, we've seen that residents plan to volunteer their time when they start to practice, and they plan to do so mainly through short-term mission trips. So with this growing enthusiasm for global surgery among trainees, there's actually been a proliferation of global surgery elective rotations in residency programs to meet trainees' demand, such that now there's 33 residency programs hosting international electives that are in accordance with the Accreditation Council for Graduate Medical Education, or better known as the ACGME. And as residents participate in these electives, several studies have explored naturally how trainees benefit from these experiences. And a lot of what we found was the same notions and echo the same findings that Dr. Joel and Dr. Green were talking about, saying that residents say that they benefit primarily from education. For example, they learn to work with limited resources, or that they gain exposure to a broader range of operative pathology. And secondary to these educational gains are personal benefits like getting exposure to foreign culture and forming relationships with colleagues abroad. So the current literature gave us a pretty good understanding of residents' interest in global surgery. We also got a sense of what motivates trainees to get involved with international work. And we also saw that trainees want to volunteer their time when they start to practice. And finally, we got a good understanding of how trainees benefit from these experiences during their residency programs. But we noticed that there was a gap in the literature. There wasn't a robust body of work examining how host facilities actually benefit from having international visitors, whether it's medical students, residents, or attendings, specifically in the area of global surgery. And this is what led to our study's objectives. Specifically, we aimed to examine how local staff perceive the role and contributions of visitors. And second, we wanted to understand the perceived impact visitors had at an international facility. So we conducted a survey of 119 clinical and administrative staff at a rural mission hospital in Kenya. The survey was distributed electronically via Qualtrics and included both open-ended and closed-ended questions. Our closed-ended questions captured data regarding demographics, perceived benefits of having visitors, the roles that they played. And we also asked local staff about what they thought motivated visitors to work overseas. And these quantitative data were analyzed descriptively. Our open-ended questions captured qualitative data that was analyzed by thematic analysis. And the questions included things, items asking about challenges faced by visitors, as well as getting some feedback on ideas about how to enhance the experience of staff with visitors. And so we sent the survey to 119 staff members and got a response from 76 of them, which gave us a response rate of 63.9%, which, considering this was an international collaboration, we were pretty happy about. So I'm going to turn it over to Dr. Parikh, who's going to share the rest of our results from our study.
Thanks, Musunga. Can you hear me?
We can hear you, yes.
Okay. So from the total 76 responses we got, most of them, like 55% of the respondents were male. almost 53% were clinical workers with a mean age of 37 years. So when we ask them questions on why they think, just keep in mind all the results and perceptions are at least in our talk is from the local staff. So when we ask them why they think people visit them, they had different motivations for different group of people, and some of it that Dr. Mitchell and Green already discussed, how surgeons or why surgeons visit them, like attendings. The staff perceived or thought that the surgeons visit because they want to perform procedures that are not commonly done over there. They want to help people in need, and they are also looking for opportunities to teach. For residents, the primary reason was that they wanted to help people, and they wanted to experience surgery in low resource setting, and of course looking for opportunities for research as well. Whereas on medical students, as you all know, they are still in the initial phases of medical training and education. Their primary motivation as perceived by the local staff was that they wanted to learn more about the diseases they typically don't see in their home countries. And they want to get hands-on training, and they also are looking for opportunities to do research. So they actually use this global health rotation for these purposes too. So from all the responses we got, most of them, like 98% of the respondents, said that visitors have beneficial impact. They benefit them and the local facility over there, primarily in terms of education, that they teach people what to do, how to do, and they increase their clinical capacity as well. However, 42% of respondents also saw the negative impact. So here you see on one side, the perceived benefit is that visitors teach them, but then one of the negative impact was that the education that they provide, here this line I'm showing you, that the education visitors provide doesn't match with their local practices, is in fact at odds with local practices. Some of them also felt that they impose their medical care concepts, especially from the Western culture. And they also said visitors disrupt their workflow. Now, interestingly enough, some people also mentioned how the patient complication rates are higher when visitors are visiting them. So they actually said the patient had more complications. That was one of the negative impact of having visitors. And you see the bar here that says other, that was more of behavioral aspects of negative impact that local staff perceived. They said, and I'm literally quoting their words here in their comments, they said visitors are racist, they are biased, they undermine Africans, they do not appreciate the help that local staff provide, they are culturally insensitive, and they oppress the local staff. Now, this was so not intuitive for us. You know, this is something different because we all assume that all the surgeons, the students, the residents who are on these mission trips, they are first of all going voluntarily, most of them. And second, they are there because they wanted to either help people or they want to learn, or either way, we all assume that they all are open-minded. They all know the professionalism. They are not making any racial comments and discrimination and stuff like that. But apparently that's not true. And this coincided very well with the thematic analysis when we asked the staff members how we can improve these experiences with visitors. The number one thing they honestly suggested was that visitors should keep their mind open. They should believe in teamwork and professionalism. And here are some comments directly that we got from the local staff members, people who responded to the survey. They said that the visitors should appreciate different culture, like Africans and medical training they get in Africa. Especially surgeons should cooperate with them and trust their ability as well. Some said that they pass racial remarks and comments. They should not be doing it, especially when they are there in their country. So you know how diversity, equity, and inclusion has become really a core part of medical training in many, many medical schools and programs. Where we see the DEI, as we call it, diversity, equity, inclusion, the DEI training in medical education from the patient interaction and from peer interaction, it's improving the work environment. I think the DEI training and awareness maybe has a way in the global health arena as well, where we actually see those, or we should at least make our students, residents, and attendings who are going on such mission trips aware of the cultural difference. Because as Dr. Mitchell said, somebody is visiting for 4 weeks, which typically students and residents do, or even at least our attendings who are not there for long term. It's actually very difficult to learn some like culture and language, but at least we should make them aware, provide like cultural humility over there, and see if that helps. So that was number one thing that staff mentioned. They also acknowledged, however, that visitors do have language and culture barrier. They also accepted the fact that they have to work with limited resources, and sometimes that actually hinders in terms of what they plan to do, the visitors plan to do, what they could offer. And they also said they sometimes don't have clear direction and expectation. So as I move forward, when they said, if we want to improve these experiences, then the facility should provide clear direction and expectation to all the visitors. And I think this is something that we can develop as an institution in the US, sending our students and residents and attendings over there. Maybe leadership can actually talk and check with the facility, the host facility, whether or not they have any clear expectations or any directions for our students and residents who are going for the elective. Other thing local staff mentioned was that there should be more opportunities for visitors to learn the culture and the language. I know somebody here, if you read the comments, somebody would enthusiastically said, teach them the language. But it's not possible to teach language when somebody is visiting for 4 weeks or 6 weeks. And I totally understand that. Trust me, I came here in the US 18 years ago from a different country when I did not speak English as much. And I could not learn English in 6 weeks. Let's say it that way. So it's not easier for us to teach them different languages, but it is definitely in our hands here for at least our students, residents, and attendings to make them aware of differences in culture, in language, and what kind of barriers they might have so that they are more open. And I really like one of the comments from the respondents that the facility should introduce more of social activity for visitors, like basketball or football or music, so that visitors can interact more with the local staff over there, so they can get better experience and they can work collaboratively more easier. Some comments staff had how we can improve their experiences is like provide the resources that visitors sometimes need, because they don't have diagnostic tests or some equipment available. Sometimes like housing and transportation is an issue too. So they acknowledged that, and they said that's something we should provide them so that this experiences overall could be improved. And some system level change that they said, and I don't know if we are already working in this area, but the staff mentioned that visitors should consider initiating exchange program where local staff can actually come to the US or some other countries, and they can learn how to do it and learn things from you here, and then they go back and apply those techniques over there. So that was really something interesting, and I thought people who are heavily involved, like Dr. Mitchell or Dr. Green and many others, we could actually consider something like this as well, if of course allowed and if possible. So these were some recommendations that local staff had in terms of how these experiences could be improved. At the end, as I mentioned earlier, maybe there is a way and space for us to introduce cultural differences awareness and and teach cultural humility to our students, residents, and attending who are going for this global health or surgery rotations, especially having like pre-trip workshop or training, just to make them aware. And we all know that our residency program, the ACGME, has already provided some core competencies of professionalism. We all apply here, but I think we just have to keep our mind open and say that, okay, it's not just for here when you work with your colleagues here in the US, but when you go outside US on global health rotation and things like that, keep those core competencies, like remind yourself and make sure that you don't comment or you don't pass any comments of racial discrimination or the place. Somebody actually said like they think the African or people in our country are either thieves or poor or borrowers, and that's actually not true. So sometimes just making our people aware could be a starting point for us, people who are actually sending our resident students attendings over there overseas. And of course, providing a clear direction and expectations to visitors would help too. As a next step or step moving forward, we would like to make this work like on a broader scale. If there is anybody from the audience or from the panel, if you think that some other institutions would like to participate in this kind of study and see what their people think and perceive visitors at their institutions, because sometimes even the local facility, their administrators may not know how their providers and staff are feeling. So if anybody is interested in this kind of study and collaborating with us, please feel free to contact me, email me, and we can take it from there. We definitely want to take a next step and make this more of multi-center type study and not just one institution that we currently have. And if you all remember, I said one of the negative impacts that local staff perceived was higher patient complications. We all understand that some post-op complications are inevitable, but if they perceive visitors as more complications to that patient, then the immediate next step we want to take as our research goes is that we want to assess the impact of visitors on patient care and especially continuity. Like what really happens after 4 or 6 weeks when the surgeon leaves there and a patient comes back with complication, how do they handle those things? So something along those lines, we should definitely, I think, do more work and assess that kind of impact so that, we all want to make sure that the patient care is optimized. That is, I think, #1 priority for all visitors and local staff and local providers. So if it is hindering or if it is limiting the patient care, then I think we should definitely assess that impact. And that is our plan moving forward. So if anybody else from the audience, as I said, from the panel, if you are interested in this topic as well, please reach out to me and we will take it from there. We already have a team here, and I'd like to thank the RCSI, first of all, for giving us this platform today. And my team, Dr. Sherry Wren, she is a surgeon and a global surgery enthusiast. She goes on mission trips many, many times a year. I don't think she needs a big introduction here. She's from Stanford University and very knowledgeable in this area. She's part of this work. And one of our chief residents, Dr. Zeke Rhodes, who was a part of this work as well, he, in fact, is planning to move to Kenya and serve population over there after he completes his residency here. So he's that committed to global surgery. So I'm very thankful to my my team, and the teamwork makes dream works. So I would really appreciate if you are interested in, then just contact me and maybe we can have a bigger team here and do more of multi-center study. Having said that, I just wanted to end with a question today. I know typically audience ask questions to the panelists, but I actually wanted to ask you all, our panelists and our participants today, if you are a host facility, a host staff there, or you are a visitor, what are your expectations and perceptions? Do you agree with some of the things that the findings that we have, or you have some different perceptions, I would really like to hear that out today. Thank you so much.
Thank you,
I'll
Priti.
stop sharing.
Thank you, all of you, for four really spectacular presentations. It's time for the Q&A session. If you all have noticed, there's a very lively discussion going on in the chat box. So if you haven't seen it yet, do check it out. There's some really good comments happening in there. If you do have questions, do push the Q&A button at the bottom of your screen and then pop them into the box there. Let me start with a question, since she was mentioned, from Sherry Wren, who asks, can someone discuss some of the other possible negative impacts of these quote unquote parachute missions, such as taking away cases from local surgeons, since the care these trips often provide are free, and potentially leaving complications behind for someone else to handle? Whoever wants to attack that one first.
Yeah, I can start. Yeah, I saw two examples of this when I was in Kenya. One was, as you talked about, many surgery residencies in the US are now wanting to send their residents over to developing countries in order for them to learn open surgery, because many times we're getting a lot of training on laparoscopic and robotic. And so they want to start partnerships with hospitals in Africa to send their trainees. And the hospital I was at did have a relationship, but we noticed that as we grew our own Kenyan surgery residency, that we were sacrificing cases for those residents to the visiting surgeons. And so we started trimming down and cutting the visitors in order to preserve the cases for our own residents. So in the case of having a surgical residency program, I think it's important to not steal cases from the host residents for the visiting residents. Now, in Dr. Green's history, in Kibagora's earlier days, they didn't have any surgical trainees. And so if you could bring along a resident or two and you could supervise 2 rooms at once, you could get twice as many cases done and everybody gets a great experience. The second example I saw that had maybe a negative impact was a team that I joined because they needed an extra surgeon, was a team from the US that came to an area close to our hospital in Kenya, but not at our hospital. And they came and set up for a week and planned to do as many thyroid surgeries as possible for goiters and various diseases. And then after that week, they left. And just thinking about how if there was a Kenyan surgeon who was desiring to come to that area and set up a practice, he'd be severely undercut by this visiting surgeon or surgery group that essentially gave free care and really disrupts the local economy of surgical care. And so although we may be trying to help, we always have to remember, are we hurting more than we're helping, both on a small scale and maybe economically in the area?
Thank you, Eric. There's a follow-on question here. First, I want to acknowledge, I didn't want to say this before so as not to make you nervous, but one of our audience members is Professor Ronan O'Connell, who's the president of RCSI. And he has, first of all, thank you, Ronan, for being here. He has a question in the chat that says, is it appropriate to quote unquote use residency programs in LMICs to provide open cases for high-income country residents?
When you put it that way, no. I think the important aspect of this, as we've discussed already, is that it would be a mutually beneficial relationship. And I'll kind of piggyback on what Dr. Mitchell already talked about. There's sometimes that the surgical volume is so high that the addition of a resident to the team is very much a welcome thing. And it lets you get more work done and offload maybe the one surgeon there who's caring for 250,000 people in the community. So I think you have to carefully balance it. And I think part of the answer to the parachute question originally was, I think if you're going into a vacuum, a medical vacuum, and trying to provide surgical care, that's probably a mistake. Because we all know that surgical complications happen, and sometimes they're worse than the original disease. And so I think you need to have some sort of partnership to care for the patients that you may leave behind, even if you're a specialist in providing something that wouldn't be available if you weren't there. You really need to have a partnership with local people on the ground who are going to be there all the time.
Yeah, I'll piggyback on what Dr. Green said. I think the most important aspect to remember is, what is your motivation for going? If your motivation for going has anything to do with yourself, you're probably have the wrong motivation. If you want to get something out of it, if you want to, as a medical trainee, you're going so that you can benefit. I don't think you're going with the right motives. I think you should really primarily be motivated by serving and helping whoever's there and what they need. And when those motivations happen, I think then it's great.
Sorry, I was muted. Let me direct this next question to Dr. Parikh and Ms. Mulenga. This is, forgive me if I mispronounce your name. This is from Soren Kudsk Iverson. Your study is a great help in trying to hear the voice of the hosts. Might I ask, one, have you looked into hearing the views of the community leaders and patients themselves? And two, what training is provided in terms of unconscious bias and, quote, roles of the visitor prior to going on international electives in the US?
Can you hear me now?
We can, yes.
Okay. So we have not. So our and please, I just would like to remind, this was just a first step towards asking a very big question on are these mission trips, or are we doing the right thing by even going there? So this was just a first step to assess their perception. So no, we have not talked to the leadership over there or patients. First of all, it's actually very difficult to speak with people over there. Please remember, the facility is in Kenya, in Africa. It was actually a tough time just to get the survey results back because of their internet issue and those kind of things. So although it sounds really great, I think we have some limitations working from here unless you have a person, somebody there. So if when Dr. Rhodes moved there, then I think it is much easier to do it that way. But you are right, we should hear back from the leadership, the patients. It's just that limitation that we are currently working on. We could not ask them directly some questions on how patients perceive having visitors and getting procedures done by some foreigner as they see it. Yes, it's a pretty good question and we should be doing it. It's just some limitations. And what was the second question?
The second question was, is there any training provided in terms of this unconscious bias that you were speaking of before people leave for their electives?
So for us, we did not. And as I said in my talk, we assume that everybody is going there out of their own will. They want to learn, they want to do something and help people. So we probably assumed that everybody was sort of open-minded. We never had this kind of question. So it was actually surprising for us that we saw people saying that visitors were racist and discriminating them against others and those kind of things. So moving forward, yes, we are actually planning that whenever we send our residents from our surgery program, and I'm in touch with the medical school global health leader as well, where we send students or residents overseas, we actually give them a short talk or at least brief information, make them aware that these things will happen. Or it typically happens and how you should be dealing with and how you should remember your core professionalism and competencies there. And just to be open-minded for different cultures and language barrier. So yes, we are planning to do it moving forward. We never did it before. So as I said, we assume that everybody is good there.
And to echo what Dr. Parikh said, I know here as a medical student, speaking from this perspective of a medical student, I would say the onus is on an institution to put together that sort of workshop or some sort of training on cultural humility. For example, here at Wright State, as a global health scholar, before we participate in any sort of service learning opportunity, you actually take a course in the fall semester before you go abroad in order to gain some of that culture humility. So as I mentioned, it would be interesting to find out what other institutions are doing and to sort of put the work on other institutions to talk to their international partners to say, you know, what do we need to do better in order to have more culturally aware students and residents that we're sending over.
Yeah, there's a lot that's going on in the US right now with unconscious bias and identifying our unconscious biases. And it's really eye-opening when you read or participate in some of these workshops and things. A couple of books that I've recommended to residents who are coming with me to go on a trip. One is by a guy named Duane Elmer, and it's called Cross-Cultural Servanthood. And he talks a lot about cultural humility and just seeking to understand what logical reasons might be there for what seem like illogical solutions sometimes or illogical behaviors in another culture. And then another book is called Foreign to Familiar. It's a short book by, let me see, I looked it up here to find the author, Sarah Lanier, Lanier. It's a short book, but it does a good job explaining the difference between some cold cultures versus warm cultures, which there's a lot of context in the cultures of many low to middle income countries. And a lot of that is missed on Westerners or high income country dwellers. So those are important because I think I have made many missteps and over the years have realized how ignorant I was in the beginning to assume certain things, or even just the way I spoke with or instructed someone on something. It was pretty insulting, and they were graceful enough not to call me out on it, but realizing that in retrospect is kind of embarrassing.
Thank you. We have got literally 3 minutes left, and I want to respect everybody's time. Chris Lavi, I see you have your hand up. I wonder if it's possible, Deirdre, could we get Chris the ability to speak?
Thank you. I'll be very quick. I wanted to say thank you so much for everyone who's spoken. Dr. Green and Dr. Mitchell, you are amazing. The difficulty is, I think you are in the top 1% of short-term visitors, and there is a whole cadre that are not as sensitive or as serving as you, and I think they're the apples, they're the bad apples that give the short-term visits a bad name. In a decade of running a small hospital in Malawi, I would get many visitors who'd get off the plane and say, "I've done Ethiopia, I've done Congo, I've done Ukraine, and I want to do Malawi now." And their attitudes were often just self-serving, as you've said. And I wanted to just add a little bit of British culture to those thinking of possible visits, and to say on the Christian Medical Fellowship website in the UK, my wife has written a couple of books. This is shameless advertising, but she gets nothing for it. One's on short-term medical trips and the other's for medical electives. They're written from a faith-based point of view, but have got lots and lots of non-faith-based relevancies. Thank you.
Thank you, Chris. I think that's a great way for us to end. Kind of along the same line, a lot of this has come up. There's a quote that I really like. It's from Gustavo Gutierrez, who's a Catholic theologian from Peru. He says, "There's no true commitment to solidarity with the poor if one sees them merely as people passively waiting for help." And I think a lot of what Dr. Parikh and Dr. Mulenga and Dr. Mitchell and Dr. Green have said kind of fits with this theme of solidarity. Thank you all for being here. This was the first of a year-long series. We will be having these global surgery grand rounds the first Wednesday of every month at 2 p.m. Irish time, which translates usually, depending on time changes, to 9 a.m. Eastern time, 6 a.m. California time, unfortunately. Again, thank you all for being here. Thanks for this lively discussion, and we will see you all next month.